Welcome to the Molecular Therapy Podcast. I'm Dr. Rory Bricker Anthony, Scientific Editor of the Molecular Therapy family of journals. This episode features a conversation between the Editor-in-Chief of Molecular Therapy, Dr. Joseph Glorioso, and Dr. Rita Perlingero from the University of Minnesota. They will discuss an article recently published in Molecular Therapy titled Preclinical Quality, Safety, and Efficacy of a CGMP iPSC-derived myogenic progenitor product for the treatment of muscular dystrophies. Before we get started, don't forget the ASGCT 2026 annual meeting is happening in Boston from May 11th through the 15th. Join us for a Molecular Therapy Advances reception on Tuesday, May 12th, and make plans to attend the Molecular Therapy Presents sessions, which will feature highly read articles published in the Molecular Therapy family of journals in 2025. Learn more, register, and plan your week at annualmeeting.asgct.org. We hope to see you there.
Good morning, everybody. I'm so glad you're here, Rita. I mean, this is going to be a very exciting session, and you guys are doing some really amazing work with, stem cell therapies for treating muscular dystrophy. And I was hoping that maybe you could give us a little background on the disease and what's been tried in the future, and where do you see your new technology interfacing with gene therapy for Duchenne muscular dystrophy?
Okay, well, thanks for the invitation, first of all, and I'm happy to be here and talk more about our work. Muscular dystrophies, are still incurable disorders, and although there has been a lot of progress in gene therapy, there is still room for other strategies. And both strategies, gene and cell therapy, are very attractive because one, you're replacing the gene. The other one, you're replacing the mutant cells with functional, healthy cells. And they have their own advantages and disadvantages, and one can anticipate a combo in the future. So in the future, why is this still important? Maybe that's the question. Why is it still relevant, right? There is a lot of progress with gene therapy, especially for Duchenne muscular dystrophy, but there is still a number of muscular dystrophies that have no therapy in sight. And one significant advantage, I would say, if this therapy is proven to be efficacious, is that they are disease and mutation agnostic. So the cells that are in the freezer right now could be used for any patient with muscular dystrophy because you're talking about allogenic cell product. And there is no issues with capsids or things of that matter. Of course, there are other issues that one can think, but there are several aspects that there are pros and cons. And I was just in the MDA meeting earlier this week, and you're talking about the combo options, how you could imagine combining cell and gene therapy together, and we start even thinking which one would go first, and so it's exciting to think about this potential for the future.
Yeah, I guess, both strategies, gene therapy and cell therapies, have their advantages and disadvantages, as you pointed out. One of the problems, I guess, is that dystrophin is a big gene and doesn't fit into the standard vectors. And so people in the past have tried a lot of things like making reduced forms of the gene product, mini genes and microgenes and genes that recombine with multiple vectors and so on. But the problem has been two things. One is that it takes a lot of vector like AAV to inject into patients.
Mhm.
And, and this vector is not completely safe. There's been some deaths associated with it due to
Right.
infections in the heart. And in addition, the outcome is that you have not a complete correction of the problem, but rather you have a less disease form.
Mhm.
And been a lot of other things like exon skipping and so on. But none of those is, in my view at least, have proven to be satisfactory so far. And so we really need new strategies, and I think using engineered stem cells is one of those. I wanted to ask you, is it possible that, or is it too complex for manufacturing to use cells from the patient and convert those cells into using Pac7 to make them, make iPS cells from the patient and then convert them? Uh,
It's doable. It's
yeah.
definitely doable. And we actually have done that too. But out of the chart for you. Oh, that doesn't need to go in the conversation. But this is the when we started the translational conversation, right? Almost 10 years ago. There was the discussion, should we go allogeneic? Should we go autologous? Right? Yes, IPS, all this, very important early decisions that we had to make. And the beauty of IPS technology, it really allows you to generate an autologous product, of course, combined with the gene editing. Right at the beginning, we thought like we just had so many questions. We didn't even know, even though in theory you can manufacture and can generate large numbers of myogenic progenitors. One thing is actually, anticipating the scalability and actually doing it and obtaining a cell product that's comparable to the cell product you do in the lab in the very small scale, right? So there was a lot of questions in the beginning related to scalability. You knew you could scale up, whether the cells you're generating in large scale be exactly the same you do in the small, generating the small scale. It was still a question for us. There were the issues with, safety. So, and adding the gene therapy to the manufacturing of the cells that they had never been done before in a CGMP manner. We thought it was just too complex, as you alluded to. But now that we have generated this, we have implemented the production of the cells successful with an allogenic product. We have the system in place for all the stages, right? And it works, and you can implement for the production of autologous cells. So I think the most now I don't have any issues with feasibility anymore, other than just the cost
Yeah,
of producing an autologous cell. How many can one make, right? So that's the beauty of allogeneic. Of course, that comes with the issues of course, immunosuppression that you have to consider, but it's just we can target a significant number of patients if we are able to move forward after the phase one, if the cells are safe and everything looks good. We have cells in the freezer to treat dozens of patients, right?
yep,
So the autologous, I like that concept as well, and we have validated it's possible. It's just that we have to also implement the gene editing in the CGMP facility eventually. So all these, add layers and add costs, right? So that's the main challenge. I think it's cost
right,
and time.
right. So in your paper, I mean, if you had looks like you had remarkable stability with your Pac7 stem cell formations, and I guess did you get any? And you got minimal replication, I guess, of those st cells after you injected them, right? Because
Mhm.
you wouldn't expect that, I suppose, if they're stem cells,
You
satellite.
mean replication like the cells being Ki67
Yeah,
positive.
Ki67 positive. And
Those cases we are looking long term, right? So when you transplant them, well, the PAC7, they are very proliferative in the dish when you are exposing the cells to PAC7 induction, right? Because so they have that
yes,
remarkable
yes,
expansion potential, right? That allows us to freeze so many vials. But once you transplant, the cells are no longer exposed to doxycycline, so they are
right.
exposed to the environment, they do what they need to do, right? So as they are exposed to this environment that needs myofiber, so the vast majority of the cells that don't die, right? Because as you transplant cells, we definitely lose cells as well, right? But the cells that engraft, the majority differentiating to the myofibers, and a pool of cells, seed the stem cell pool, and as the regeneration or resolves, following the injury or following the irradiation, they tend to kind of go to a steady state, right? So we haven't in this paper, right, subjected the cells to multiple rounds of injury. So when you do that, they respond, they
Right.
proliferate and make more fiber. So you keep doing that, they responded to the stimuli. So the studies that we show, I think it's figure 3 or 4, let me see here, that we show that they have, I think it's 3. Yeah, I think it's figure 3. That we show is like lower than 1%. Those studies were done in NSG mice. So these mice are not being exposed to multiple, they after a month they're done, right? So there is no reason for the cells to be proliferating and differentiated. So the cells, what I think these results show is that the cells will respond to the stimuli in the environment that they are exposed to.
Why do you need to treat with cardiotoxin? What does that do to I know it preps the environment
So
for
the cells, yeah, that's a good question. You always have to bring that up in papers and grants.
Sorry.
No, that's fine. It's like, because it is, even when we started research many years ago, I still remember the postdoc knocking my door. Should I do cardiotoxin or not? In the MDX. And my first reaction is like, well, it's a mouse model of Duchenne. Why would you need it to do injury, right?
Yeah.
But my answer is like, you know what? We are not sure, since we see almost virtually every paper with cardiotoxin. It's like, well, let's do both, right? So, and if you don't, you really see more in the MDX. So let me just back up. Why do we do injury? It's really to create a highly regenerative environment for the cells to do their job, to promote to regeneration. It's really the cues, the signals that the injury promotes. So obviously we need cardiotoxin in an NSG model, right? Because there is no muscular dystrophy there, or
Right.
into the non-human primate. Why do you need cardiotoxin injury in a mouse model of muscular dystrophy? So you see virtually most of the papers in the MDX mouse model will use or cardiotoxin or irradiation to ablate the satellite cells. And the reason for that is that, in particular in the MDX, there is just the satellite cells are highly active. So there is a lot of competition. So if you don't induce some kind of ablation on injury, the cells really there is a big survival, or fighting for regeneration, right? But this is very peculiar to the MDX. So when we perform transplantations in the double knockout for the dystrophin and utrophin, that, in a way it's much more severe and one could say more similar to the disease, right? That was not necessary. We just inject the cells directly into the muscle without any pre-injury. So the same we have seen with another model, the fukutin-related protein mutant mouse model. You can inject the cells without any pre-injury. And it's not as severe. So there are all these peculiarities among different animal models and, the regenerative environment that the cells are exposed to. In the paper, we subjected both to radiation because we just want to have them, subject to the same conditions so you could compare apples to apples and not make everything more complicated, right? But yeah, so it's more really to create the environment in the mouse model that's not perfect, right? Doesn't really fully recapitulate human disease so we can assess the capacity of the cells.
I see. So, in preparation of those cells, I guess you sort them on the basis of MyoD, or how do you sort those cells? CD54?
CD54, yeah.
Yeah.
And so that was a very important aspect that we needed to figure it out very early on. And we started discussing translation, right? Because in the early studies, when we first developed the protocol for human pluripotent stem cells with PAC7 that was published in 2012, we were relying on transgenes. So the PAC7 expression we could purify using transgenes like RFP or GFP, which works beautifully. You purify PAC7, that's great, right? They do. It's exactly our target cell population, right? PAC7 positive. But obviously, we couldn't use GFP or RFP for clinical applications. So very early on, then following, as you started, gearing towards translation, we performed studies with the goal to identify surface markers that were upregulated after upon PAC7 induction, and we identified CD54, alpha 9 beta 1 integrin, and syndecan, and so we identified three. This was published in Cell Reports in 2017, I believe. But I was very excited because we have three surface markers, and they are all the same population, right? So we identified that PAC7 positive cells, we have the upregulation of these three surface markers, and the population is really triple positive, right? So I was very excited because we actually have three. But talking to my colleagues that have a lot of experience with clinical applications, like, wow, Rita, for translation, one is better than three. And I was like, okay, in the basic science, three is better than one. So that's okay. So, one is better than three because it's cheaper. And if you can use Clinimax, that's even better, right? And so CD54 answered all those questions because CD54 was, all three, any of those three could work, but CD54 was available for Clinimax purification. And it was also the brightest, which is very important for separation using beads. So that worked very well for us.
That's great. So these new fibers are formed by fusion with satellite cells? Is that how this works?
We believe it's both. They form new fibers and they also fuse to resident cells.
So how widely distributed are these cells? I know you inject something like 10 to the 6th cells or something like that.
Yeah, we did dose escalation, in the monkey, you're able to inject up to 60 million cells, right? As I mentioned, with any cell transplant, that is loss, right? So we can think of ways of trying to minimize that loss after transplants because the cells are really, there's a lot of stress going to the injection and hitting this environment. So you can imagine of, optimizing strategies to improve or minimizing the cell loss. But because we don't really have issues with cell numbers, we don't worry too much about it, but that's, it is an area of investigation. But, just to your question, in terms of efficacy, well, we can say that about 1 million cells, we get in average 200 fibers in this system.
Yeah. Oh,
in this
so you
system,
actually know
right?
the ratio.
Yeah, so it depends on the system. Like in the sixth, when you're doing in the monkey, you are able to get up to 600 fibers, right? So it's it depends on the system. So we try not to extrapolate too much, right? We don't know exactly what you see, but I think we can say because we have done a lot of the 1 million transplants across NSG in SGMDX, in SGFKRP, and in average, it would be about 200 fibers with that number of cells injected. And in terms of, I don't know if that was you were alluding to migration, they have the capacity to migrate. And, to your first question, right, actually, there has been, sometimes you forget about those very early studies because many years have passed, but there was an excitement about cell therapy in the early 90s, right? There was a transplantation studies with myoblasts, a lot of excitement on those early studies that were, initial work from Partridge and Kunkel, and that led to clinical trials, and there were many actually. But there was more than 20 years ago, a lot of the tools we have now were not available. So there was some studies that were showing, oh, there's engraftment, and others couldn't confirm because it was just the detection, right, was not as good. But the main conclusion from those early studies that the myoblast probably was not the right cell because it's already
Premature.
downstream in the hierarchy,
Yeah,
right?
yeah.
So limited migration, limited survival, and so on. And so, in the field of muscular dystrophies, myoblasts, I think, have been abandoned, but it's still being used for more localized, very specific areas like incontinence, for example. We just recently were working a review, and you see that, some there is still some applications that a more differentiated cell can be useful.
Yeah. I was wondering, like in patients, usually they have heart failure or diaphragm failure. Are you looking at these tissues with a similar approach? Or?
I'm looking at the diaphragm, which is a very exciting muscle and important muscle to look at. Yeah, so we are working on that aspect right now.
I see.
The heart, unfortunately, is out of our scope.
Okay. You can't use PAC7 to make my heart muscle cells, I guess, right?
Right. Yeah, the heart is a whole different tissue, right? I mean, because the heart, you could imagine that you could generate cardiomyocytes and they can, provide some benefit. But because the heart is not regenerative, we don't really, maybe, for the heart, you'll be more appealing combined the gene therapy doing its job in the
I
heart
was going to say
and
that.
the cell therapy in the skeletal muscle, or in combination, of course.
Yeah. Okay. Well, that's really exciting. So I guess one of the things that people worry about is if there are a few stem cells that are not transformed, there's the possibility they can form teratomas, I guess. But you haven't seen that in your studies, whereas if you just inject stem cells that haven't been treated with PAC7, then you get teratomas.
Right,
So
no, and that's a very important point, right? And
yeah,
a reasonable concern. It was our concern too. And of course, you have to do all the different steps to make sure that that's, control or taking care. So that's for sure for us, it was a very important aspect. Well, I think it should be for any investigator interested in translation for their cell type, whatever that is, from pluripotent stem cells, is to have the purification step, right?
yeah, yeah,
And make sure, of course, that the release criteria that it's you are devoid of pluripotent stem cells in your product, right?
yeah.
But you can never see zero because zero is very hard to achieve
I
in
know.
science, right? As you
Well,
obtain
that's what I was going
those,
to say. The higher
yeah,
the dose, the more. I don't know if it's 1% or 0.01% or something like that, but you probably know the answer to that.
right, under one. And and that's why for me was very important to do the studies in the non-human primates.
Yeah,
Because, when you are like doing these studies in the mice, and that's the standard, right? Like, well, the maximum number I can inject in a mouse muscle is up to 5 million will be the max, right? In
yeah,
a given for the volume, right? In the area. So that's, and then if you think, well, in the 5 million, if there is 1%, what would be the number of cells? Is this system sensitive enough to capture, right? Any potential. So I felt much more comfortable when you're able to inject 60 million, which is the number that's, very
Yeah.
close to what you inject, and you don't see any teratoma forming cells, anything abnormal in the tissue. So that's very reassuring to us.
I guess you could build in a
Mhm.
self-destruct mechanism or something like that.
Right.
Um,
And we talk about, we talk to different investigators or even consultants, right? What's the best way, right? And
mhm.
we talk about, oh, how many mice did you inject and multiply that? Like, for example, you inject 2 million cells per mouse and you inject 100, so 200,000 million in the end. But it's not the same thing because it's a dose in a particular recipient, right? Yeah, so I think combining also long-term studies, right? Because you can be performing the teratoma study per se, but having injecting as many cells possible and leaving them long-term as well. So I feel it's a combination of data that gives you insurance that
Yeah.
hopefully the cells are safe, right? So you look at long term, you look at the profile, you look at the characteristic of the cells, you perform large number injections. So I think all this is very important for the whole safety profile.
Yeah, I guess another thing that crops up with this is that an inflammatory response. I guess in these patients, they do have considerable inflammation, right? And
Mhm.
recruitment of macrophages and probably T cells and so on. But what's your thoughts about how do you quell that down? Because that could advance rejection of your transplant.
Mhm. Yeah, so for the mouse studies to have a clear idea of the regenerative capacity of the cell, since this is a human cell product, we are using for all the mouse studies immunodeficient animals, right? Which obviously is not the environment the cells will find in the patient. In the non-human primate, even though it's very similar, we use a strong immunosuppression regimen, right? Because it's still a xeno. In the patients will be immunosuppressed, and the plan, and my colleague is leading the clinical trial, because this is a cell transplant, is allogeneic, the patients will receive tacrolimus.
Right. Well,
So this should theoretically modulate. We don't know. Is this sufficient? We don't know. So those are answers that we will get soon, I guess.
right. How many patients are in the trial now?
We are still enrolling.
Oh, you're still enrolling.
You'll be surprising that, I thought that the hardest thing would be to produce the iPS-derived drug product, but actually recruiting is also very hard right now because of all the number of trials, ongoing trials for Duchenne, right? So the trial is for non-ambulatory, 18 years and older,
Hmm.
and the main goal is safety. So it opened about a year ago, and
But you anticipate in the future treating children, right?
that's the plan. Yeah,
Yeah. Okay.
that's the plan. The FDA didn't allow us.
Yeah, I understand.
Even 18 and older, no ambulatory, right? Because it's a first in human, and I understand. So how many patients? So the main goal is to make sure the cells are safe. So, ideally a handful of patients.
Mhm. Has there been any interest in trying to stealth your product? Because, for example, you can introduce genes like CD47, this don't eat me kind of thing, and other products that can.
Yeah, so again, right, after having the proof of concept, like, because again, we had all these discussions of, oh, how can you make the cells, there are a number of investigations around for different lineages, right? How can you make the cells hide from the immune system? So I think that would be, a next generation, a potential
Yeah.
for a next generation drug product, because again, when we start, okay, we need to start somewhere, right? Or
Of
do we
course,
start to have that, right?
of
But I
course.
think these are all good ideas. So potential, right? So if the cells are safe and everything is good, right? These cells that are in the freezer can move on to next phase, different muscles, different diseases, younger, hopefully, and a future systemic, of course, a new IND. But in terms of drug product, right? This is the first one, but I can envision autologous, which we already talked, that is the constraints of
Yeah,
cost, right?
yeah,
But then, in terms of the allogenic, I see two paths, right? And one is not, they can run potentially in parallel. I envision having a bank of different flavors of HLA, right? That you
yeah,
can, how we do with organ transplant, you can look for a
yeah,
match
yeah,
and have, a number of different flavors of HLA in the freezer. Of course, it's cost, but, it's doable if you know that works, right? And then the idea of hiding the cells from the immune system, right? So, of course, that involves more genetic modification,
I
which,
know.
we know is doable, right? But with genetic modification, there is always, comes, right? Changes with more modifications we do with the cells in the dish, more changes it might happen to the cells, and you don't know what can that entail, right? In terms of abnormalities. But again, you need to test the cells. And so I find that's very exciting because then again, if you generated a cell that can hide from the immune system and, then again, you can have one potentially, right? It's just part of me also get a little bit hesitant in hiding from the immune system because the immune system
Yeah,
exists for a reason.
exactly.
So I'm more inclined to the bank with different flavors of HLA.
Yeah.
But research-wise, it's exciting, and I think we should. It's a good strategy to explore as well.
I think aren't there some HLA types like HLA-E or something that are less immunogenic or something like that?
Yeah, so we have efforts in the university, towards that goal because there are some HLA types that are, if you generate a cell line with that, it can target potentially, it's not 50%, but let's say up to 30% of the population. That's significant, right?
Yeah.
So we started with that. That was an original idea, but then, you had to find what is the HLA, and then you have to make the IPS,
Yeah.
So there was a whole process, right? And I felt I knew that the process of even manufacturing, optimizing the method, transfer the technology to the clinical grade facility, it did take a long time. So if you had to start from zero,
Yeah.
identify the cell, characterize the
No, I think
cell,
you're doing it the right way for sure.
yeah. So we thought like, now we can go back, right, and
Yeah.
just put the cells in the pipeline. It's doable. But
Yeah.
yeah, definitely that's a good way to try to minimize immune response and still be affordable with one line.
Yeah. So I can't wait to see the results of your trial. I think
Me too.
I'm pretty sure you're going to get safety covered. Then it's going to be exciting to see, how many muscle groups you can actually rescue. And I mean, it would be a big deal if these patients could just stand up and walk. So
Yeah.
it's a terrible progressive disease, and I'm so grateful to you and your team for
Oh, thank you so
on
much.
this.
Thank you so much. We're excited, and I'm glad, we got our story published in molecular therapy.
Okay, wonderful.
I'm happy to answer the questions you had. They're all important ones. And I think one aspect that, that's important in cell therapy is just, and I think it's important for any treatment, including gene therapy, is we focus a lot on the cells we are generating or the product, be whatever, right? The product that we are using to fix the primary defect, right? Be dystrophin or other other genes that are mutant. But one issue that's very important, and it got really more and more to my attention as we were developing this, is the environment, right? So, we talk to patients because we have muscular dystrophy day at the University of Minnesota, and the patients come in a wheelchair, and then too late, right? And then too advanced, right? So the beauty, if you will, right, is that different muscles are affected at different speed, right? So for a cell therapy, and I think, it's the same for gene therapy, I might be wrong, but, you need the muscle to have some level of integrity, right? So
Right.
if the muscle is
There's nothing
totally
to build on.
it is nothing to stick, right?
Yeah.
So the disease pathology is very important, and I think that the state of the muscle, right? So the beauty is that, the muscles that are still not totally gone, hopefully we can target, right? And have an effect. But we are working towards, if as we see muscles that are already advanced, can you condition that muscle to receive the
Yeah.
cells, right? So just, a thought in the environment, right? Because we focus a lot on the drug product, that's what we have been working non-stop in the last few years to get to this point, right? So, okay, so now it's in the clinic, so wow, what? So we needed to work, of course, it's still on the drug product, as you brought up, next generations, how to, be able to be applicable to patients without having less worry about the immune system, right? But also, how can you make the environment for muscles that have the disease more advanced, more a better environment for the cells
I'm
to.
just wondering, when you treat with a cardiotoxin, maybe you induce hormones that are very helpful, not just
Mhm,
an inflammatory response.
mhm,
And, maybe growth hormone or,
mhm.
or something like that. And if you knew the answer to that, then maybe you can improve how well these cells, tr take in the tissue. Also, I was impressed with your retrovirus system because it's self-inactivating, right? And you don't want to.
Mhm.
Retroviruses are notorious for
Yeah, yeah.
activating oncogenes and so on.
Yeah,
So
yeah, yeah.
that's
So that's another part we switch it because we are lentiviral vectors first generation. We're not worried about that because it was basic science, right? And as you were evolving um, to clinical translation, it was important to use third generation lentiviral vectors. I think there are even newer generations probably, but we reach out to collaborators that were using this in gene therapy trials and showing the
right.
safety. So we felt, okay, this is good. Because that's very important to really allow for the cells to expand. And one say, why do you need it, right? And that goes back, just to wrap up to an important point that is why don't we use the muscle stem cells? Why do we have to go to a pluripotent stem cell, right? With all the risks of teratoma and so on. And the issue is that we don't really know how to expand adult stem cells in the dish, right? They differentiate, they
Right.
make myoblasts. So, it sounds like it should be simple, right? Simpler than actually make myogenic progenitor from pluripotent stem cells. But
Yeah.
it's very challenging. This once you put satellites or any adult stem cell in the dish, they make daughter cells, right? They make the progeny, they differentiate it. So you can keep them for a very, maybe elusive few hours, but they differentiate it. So then by the end, you have a mixture of cells, and so that makes it challenging. That's why you used to think that this strategies really powerful, has the lentiviral. So you have to make sure the cells are safe for integration sites and all that, what you show in the paper. But they allow for that massive production, right?
Okay, well, look at it's very kind of you to spend some time with me on this. It's a very exciting program, and I wish you all the luck in the world. I hope this is a new generation of treatments that's going to make a difference for patients.
Thank you so much. I hope so too.